Hello all, welcome to the session on thrombotic thrombocytopenic purpura. As the name suggests, thrombotic implying the formation of multiple thrombi in various blood vessels, thrombocytopenia referring to a lowered platelet count, and purpura being a clinical manifestation of thrombocytopenia. Coming to the pathophysiology of this disease, it results from a deficiency of ADAM-TS13, which is a metalloprotease involved in the breakdown of multimers of von Willebrand factor. The disease can be caused due to a genetic defect causing this deficiency, which is called as Upshaw-Schulman disease, or maybe due to the formation of antibodies against ADAM-TS13 metalloprotease. Now, this is also referred to as a primary or idiopathic TTP. Excess of these von Willebrand multimers inside the process of clotting by enhancing platelet adhesion as well as aggregation. So this will result in the formation of microthrombi at various sites, parallelly resulting in the consumption of platelets for the above said process. The same has been depicted in the diagram, which is shown here. So as you can see, there are platelets as well as the von Willebrand factor multimers, which are at an equilibrium when the protease is being acted upon and preventing the formation of the multimers to be in excess. But when these multimers are in excess, with the absence of protease, it results in excess of platelet adhesion and aggregation, resulting in a consumptive coagulopathy. Now, after the microthrombi are being formed in various blood vessels, most commonly being the kidney as well as the brain, resulting in AKI and stroke, the RBCs which are passing through these partially occluded blood vessels get broken and result in what is called as microangiopathic hemolytic anemia. Now, coming to the clinical features of this disease, it is characterized by a pentad of fever, thrombocytopenia, microangiopathic hemolytic anemia, acute kidney injury, and neurological features characterized by acute stroke. Now, coming to the investigations of this disease, a complete blood count will reveal the presence of anemia as well as thrombocytopenia. Evidence of microangiopathic hemolytic anemia can be backed up by a raised indirect bilirubin, by raised levels of lactate dehydrogenase, by reduced levels of haptoglobin, by an increased level of reticulocyte count, and a negative Coombs test ruling out autoimmune hemolytic anemia. Additionally, renal function tests as well as neuroimaging to look for brain damage are also supportive. Coming to the treatment of TTP, plasma exchange has been proven to be the most promising treatment for TTP, as it involves in the exchange of the pathogenic antibodies to the metalloprotease for normal plasma containing none of these antibodies. Some studies show benefit with usage of glucocorticoids, rituximab, cyclophosphamide as well. And performing splenectomy has a very doubtful role in the treatment of TTP. Coming to the main differential diagnosis of TTP, it is called as hemolytic uremic syndrome. So this is caused by enterohemorrhagic E. coli of the serotype O157H7, which is mimicking TTP in all aspects except that it characteristically does not have fever, and there is an initial onset of gastrointestinal illness characterized by diarrhea as well as abdominal pain, and most commonly it's seen affecting children. So this was a short informative session on thrombotic thrombocytopenic purpura as well as HUS. Hope this information was useful and hope to see all of you in the next video. Thank you for your patient listening.